Hi, I am so delighted to meet you in the program of 3 p.m. 3 Point Medics. We have been discussing about hyponatremia. So we have come to a stage where we are discussing clinical cases one by one. So last week we received one patient who presented with severe giddiness and occasional altered sensorium and extreme tiredness, was found to have serum sodium of 115. Then we evaluated as we approached hyponatremia earlier. So how will you evaluate hyponatremia? The first investigation that has to be ordered for evaluation of hyponatremia is serum osmolality. In this patient also we ordered serum osmolality, which turned out to be 264 milliosmolality per kg. That means it is less than 275. So when you have hyponatremia, we expect naturally decreased serum osmolality. In this patient also that has happened. But very few occasions where in the presence of hyponatremia you can have normal or increased serum osmolality. Those conditions are called pseudohyponatremia. Pseudohyponatremia can be produced by presence of paraproteins and presence of high lipids and presence of mannitol administration and glycine administration, radio contrast administration. So once serum osmolality is low means all these causes of pseudohyponatremia ruled out. So in our patient also serum osmolality is 261, so we comfortably ruled out these causes of pseudohyponatremia. So once we are very sure that we are dealing with true hyponatremia or hypotonic hyponatremia, the next game changer investigation is urine osmolality. We ordered urine osmolality. So urine osmolality turned out to be 215. Now, as I told you earlier, urine osmolality will divide 16 causes of hyponatremia into 4 causes as in one group and 12 causes as in another group. So when urine osmolality less than 100, only 4 causes: BPT-I, B for Behr-Potamania and P for psychogenic polydipsia, T for T-TOE syndrome, I for inappropriate IV fluid. So BPT, Bachelor of Physiotherapy, and I. So this patient serum urine osmolality is more than 100. So all the 4 causes ruled out. So now 12 causes are there. Now the headache starts. Among these 12 causes, then you have to segregate into 2 groups. Then we did urine spot sodium. So urine spot sodium turned out to be 118. So urine spot sodium usually we expect less than 40 or more than 40. Less than 40 means all the causes of hypovolemia. So here the urine osmolality is more than 40. That means we have ruled out the cause of hypovolemia, including diarrhea and vomiting and burns and intestinal obstruction, pancreatitis and so on. And we ruled out false hypovolemia also, including organ failure, heart, cardiac failure and liver failure and nephrotic syndrome. So now we have come to a situation where this patient has decreased serum osmolality and increased urine osmolality and increased urine spot sodium. So this condition fit into only 5 causes. 2 endocrine causes, hypothyroidism and mineralocorticoid deficiency. And another one is SIADH and thiazide diuretic and cerebral salt wasting syndrome. Clinically, cerebral salt wasting syndrome occurs in those who have subarachnoid hemorrhage and they should have some kind of cerebral pathology. So clinically we have ruled out. Before we rule out 2 endocrine disorder, we want to take SIADH and thiazide diuretics out of these 5 causes. We completely scrutinized our prescription. So initial self-medication written by staff nurse showing only telmisartan. So we thought that there is no hydrochlorothiazide. So we naturally thought of probably SIADH. So we did serum uric acid, but serum uric acid is 4.9, almost normal. We expect serum uric acid should be very low in the case of SIADH, something it may be as low as 1.5 or 1.7, something like that. So we are not able to conclude SIADH also. We are not able to find any hydrochlorothiazide or non-thiazide diuretic in the self-medication written by staff nurse. So we got confused. So before we order these 2 endocrine deficiency, we wanted to check once again patient prescription. Then we checked the patient's prescription. It was written as Telma-H, telmisartan with hydrochlorothiazide. The staff nurse who had written telmisartan with hydrochlorothiazide as simply telmisartan. So always you check original prescription when you suspect drug-induced hyponatremia, especially hydrochlorothiazide. Don't simply trust or believe on the self-medication written by staff nurse or whoever. So you have to prove with your own eyes. Okay. So naturally this patient is nothing but thiazide diuretic induced hyponatremia. So we didn't order any cortisol level or thyroid level. So we are very comfortable that we are dealing with thiazide diuretics. So this is the way you have to analyze hyponatremia. So basically any hyponatremia, order serum osmolality, then order urine osmolality, then urine spot sodium, then if things are warranted, serum uric acid as well. Then always clinically check whether the patient has signs of hypervolemia indicating organ failure or signs of hypovolemia indicating diarrhea, vomiting and burns and pancreatitis and so on. So clinically the most important point is whether the patient has euvolemic status or hypervolemic or hypovolemic. That's very, very important. That may give rise to some clues rather than absolutely relying on simply these all 4 investigation. Thank you.